When patients and families go into the clinical setting, being at a hospital, ambulatory setting, physician office, they go in with the mindset that they're going to either have their healthcare improved or that nothing will change. But sometimes things happen. Medical errors happen, adverse event, patients are harmed. And when that happens, patients and families' lives are turned upside down. What we often meet after we are harmed is silence. We go in with the notion of feeling better, and sometimes we don't leave at all. But what's difficult is after we are harmed, that no one tells us what happened to us or our loved ones. You see, we can accept the first harm because it's unintentional. But when you harm us again by not being truthful with us, by hiding medical records, by not talking to us, you are harming us again, and this time it's intentional. We carry a lot of grief after we've been harmed personally or a loved one has. We often feel alone, isolated, betrayed, and abandoned. We don't know what has happened in our care or loved ones, and we get in this sense of what if? What if I'd have gone to another institution, seen another provider for a second opinion? We carry this heavy burden. So what is it that patients and families want to know after medical harms? The first thing is, tell us what happened. And when we say tell us what happened, we mean what we want to know, not what you think we should know or what you feel comfortable telling us. It's what we want to know. And for some people, that may be, tell me what happened the minute I walked in the door or when I left. Or for others, it may be, I have these 3 questions and I only want you to answer those. But it's what we want to know. The next thing is take accountability. And when we say take accountability, that is that you need to say, yes, we did this. Whether it was an adverse event, it was obviously not meant to harm them, but we carry again the grief. We carry the responsibility if you all as an organization and as providers don't take accountability. The third thing that we want is 2 of the most powerful words said to us in the English language, and that is, I'm sorry. I'm sorry this happened to you. I'm sorry we did this. And that I'm sorry needs to be authentic and real and heartfelt. And the final thing is, tell us how you're going to fix the problem. The one thing that you will hear unanimously after patients and families have been harmed is they want to make sure what happened to them doesn't happen to anyone else. That is the one universal thing that they want to make sure, because they know oftentimes their lives are destroyed or turned upside down, and they don't want to see anyone else suffer. When you look to the literature, you see these 4 things. I actually believe there's a 5th, which is really important, and that is, let us be part of the solution. For some people, going back to the very organization that harmed them or the provider or the ambulatory setting, they're giving you a gift to go back and say, I want to work with you. For some people, it's making sure the problem's fixed. Others, it's honoring a loved one. And for some, it's just a way to heal. What's important with all this, though, is that you have to capture the story, the narrative of the patient and family. You cannot do a true full cause analysis if you are not talking to the patient and family afterwards. You see, you all as providers are guests in our lives, in our rooms. I give the analogy, it's like a revolving door in a hospital setting. You come in and out multiple times a day, multiple people for 5 or 10 minutes at a time. You see your snippet of the story, of the picture. We are there 24/7. We see the whole picture. If you're not capturing our stories, you're not getting the full picture. The other thing is, Patients and families need to tell their story. They need to be heard, and they need to be validated that what they share is important to the organization, to the providers, to the nurses, to the healthcare clinicians. So when I say we want to be part of the solution, you need to include us. As much as we want to be included in it, you need to make sure that we're there, that we feel that you've heard us, that you're changing the system, but most importantly, you're learning from this event. What happens after patients and families have been harmed is they have to find a way, connecting the heart and the head again, is how do we trust again? How do we go back into a clinical setting when we've been harmed? How do we get over that fear, that post-traumatic stress disorder? All of these elements have to connect again. And so much of this is built and destroyed because of trust. I am here today telling you this because I live this. I lost my 9-year-old daughter, Alyssa, to multiple medical errors. And it took the organization 3 years, 7 months, and 28 days to have the first honest conversation with me. There was no trust. And trying to build and regain that trust doesn't take minutes, days, months. It takes years. Tom, on to you.
Carole, thank you so much for sharing your thoughts. When I think about trust in healthcare, sometimes trust is earned. At other times, trust is more akin to a blind faith, a hope that you'll be well cared for when you enter the scary world of medicine. But what's certain is that when something goes wrong, that trust is severely threatened. When we think about the nature of trust in healthcare, it's important to remember that trust really is a precondition. It's an essential part of healthcare that is high quality, safe, patient-centered, and equitable. Trust, as I think about it, has multiple domains. Trust in a provider's competence, trust in their honesty and integrity, trust in their ability and willingness to advocate, to put your best interests first. And when something goes wrong in healthcare, it threatens all of the domains of trust. And one of the reasons this is such a good topic for this trust initiative is that harm events provide a stress test of an organization's commitment to building, to maintaining, and to repairing trust. Well, one way that we rebuild trust after harm events is through the way that we communicate with patients who have been harmed. And we wanted to give you an example to think about. This is an old example. It's in the pre-computerized physician order entry era. But an internist at your hospital admitted a patient yesterday afternoon with chronic obstructive pulmonary disease exacerbation. The doctor wrote the patient's admitting orders while she was in a hurry to get home for the evening. The sloppily written 10U order for 10 units of insulin was read by the nurse as 100 units, 10 times the patient's normal dose. The patient received 100 units of insulin last night and was found 3 hours later unresponsive with a blood sugar of 35. The patient was successfully resuscitated and transferred back to the intensive care unit. This morning, he's feeling well and is transferred back to the floor. So what we're going to do now is watch an interaction with the doctor who wrote the prescription coming in to talk with the patient about what happened. And I hope all of you are doing your finger exercises and stretching because we're going to ask you to put in chat what you think this doctor does well and what you think they should have done differently.
Good afternoon, Mr. Thompson. I came by to see how you're feeling today.
I'm certainly feeling better than I did this morning. I blacked out, and they had to rush me to the intensive care unit. Things seem to have pretty much calmed down for me now. I had no idea I was so sick.
Actually, I wanted to talk with you more about what happened this morning and why you had to go to the intensive care unit. Now, as you know, patients with diabetes can have wide swings in their blood sugar. This morning, your blood sugar dropped all the way down to 35, which was dangerously low. This is why you passed out. Now, fortunately, we were able to get your blood sugar back up to a normal range, so I anticipate things to go smoothly from here on out.
That's sort of odd. My blood sugar has never been that low before. What do you think caused my blood sugar to be so low?
I'm almost positive it was a bad reaction to the insulin you got this morning. Now, we have adjusted your dose somewhat, so this probably won't be a problem in the future.
Bad reaction? What do you mean a bad reaction?
Looking back at your chart, it appears that you got more insulin than you needed. Now, we have a better sense of how much insulin you require, so this isn't likely to happen again.
I have been on the same dose of insulin for the last 4 years. Exactly how much insulin did I get this morning?
It appears the nurse gave you 100 units of insulin rather than the 10 units you normally take. Apparently, there was some kind of miscommunication about what your normal dose was.
What? 100 units? You've got to be kidding me! What kind of a moron would give a patient who usually gets 10 units of insulin 100 units? Well, that could have killed me!
I understand why you're angry, Mr. Thompson, but there's no need to yell.
You'd be yelling too if someone almost killed you. Do you people have any idea what you're doing here?
The good news is the episode that happened this morning didn't cause you any permanent harm. Now, occasionally things like this do happen in the hospital, much as we try to avoid them and prevent them, but what I would really like for us to do, Mr. Thompson, is work together and focus on moving forward and getting your emphysema under better control so that you can go home from the hospital.
I want out now. I don't want to spend another minute in this hospital. No wonder no one would tell me why I had to go to the intensive care unit.
So let's chat a little bit about this video. And I'm seeing lots of chats about things that the clinician could have done differently, but were there things that you think that this physician did that was effective? And Carole, maybe we can start with anything you'd like to share. You gave us a very thoughtful list of what you expect will be shared with patients and families when things have gone wrong. Did this doctor do anything that you found was effective?
Yeah, I think we always look at what goes wrong first versus what is right. She was trying to tell him what happened. Did she do it in the best way? No. There's a great article out there by Fine that it talks about just sort of skirting around the issue and not being direct and to the point. When he started becoming a little frustrated, she kept her cool somewhat, tried to still be present with him and take care of him. But in the chat, Tom, there's some great comments about, the lack that there wasn't honesty. But someone did put in there in the beginning, using good open-ended questions, keeping calm, trying to her tone was, trying to be pretty even keel.
And I agree with all of those things. For those of you who have been in this position, it is very difficult to stay calm when someone is directing their anger at you and to not get defensive. But let's talk about opportunities for improvement. Carole, were there any things coming through in the chat that were particularly caught your eye?
So I love this one that Phyllis just put in, which I think is a really important one, is we need to sit down and be at eye level when we're having these conversations. There's still a hierarchy gradient. So if you're standing there and the patient is laying in the bed, there's still that power gradient. So really sitting down with them, the ability to touch them if you think it's appropriate is a really, really important one.
the nonverbal part of communication is really important. And we scripted the dialogue. These were both actors. But we just let the actors do what comes natural in terms of their nonverbal communication. And did anyone notice what the doctor did when the patient asked? Well, first of all, when he started to yell, she takes the chart and uses it sort of like a shield. But then what did the doctor do when the patient asks exactly how much insulin did I get this morning? She opens up the chart and looks down at it as if to say, I don't know. This is a pretty common problem here at this organization. Let me refresh my memory. Oh, it looks like you got 100 rather than your usual 10. That nonverbal was a part of trying to sort of minimize what happened and suggest that it was not such a big deal. So nonverbal communication is important. Lots of people have noticed that or commented that they thought the physician was not honest or was misleading. And what I think is so interesting about that is all of the things, with the exception of what the doctor said initially, when she said you had a bad reaction to the insulin, which, she meant by that it was an unfortunate reaction. It was a normal reaction to too much insulin. But everything else that the doctor said was factually correct. There was a miscommunication about your insulin dose. You got more insulin than you needed. It appears the nurse gave you 100 rather than your usual 10 units of insulin. Those are all factually accurate. Carole, do you have a sense then of why people get the impression that this is so misleading if the doctor is saying things that are actually all true?
Part of it, I think, Tom, is it's the presentation of it. And it's also that, some people put in there, they felt like it was really a non-apology. So if you don't feel that they're sincere, you're not going to necessarily believe what they're saying. And so I think it's everything from, how you walk in the room and what you do before you even speak sets the tone of how people are going to perceive what comes out of your mouth.
The way that we respond to these harm events really matters deeply. As Carole said at the outset, we oftentimes don't have choices in patients being harmed, but we have lots of choices in terms of how we respond after harm. And the reason this is so difficult is that we all have natural reflexes. We come hardwired from the factory with reflexes that either can support or that can inhibit effective responses to patients and families after harms. The helpful ones are our desire to share information, to comfort, apologize, prevent the event from happening again. Unfortunately, these helpful reflexes are often swamped by ones that are less helpful. The urge to keep information to yourself. Think about a time when you've been involved when something went wrong professionally or personally. This urge to sort of think, well, do I have to tell anybody? If I just lay low, keep this to myself, maybe no one will ever find out. To rationalize, well, maybe this wasn't such a big deal. Maybe it wasn't my fault. To blame. A lot of what is happening in the field in terms of developing programs to respond more effectively to harm events is to help clinicians hardwire the helpful reflexes and not being overwhelmed by the less helpful ones. Patients and families also have reflexive reactions, but at the end of the day, we have a fundamental obligation as healthcare workers to respond to harm events in ways that support patients and families rather than traumatize them further. But unfortunately, often what we end up with is something like this gentleman who's at the false apology greeting card section trying to choose between, I'm sorry you feel that way, I'm sorry you got mad, I'm sorry you misunderstood, I'm sorry I don't care. Obviously, when these conversations are not handled effectively, it just compounds the suffering of patients and families. So what are communication and resolution programs? These are principled and comprehensive and systematic and compassionate programs to both prevent and respond to harm events in healthcare. They have several key elements: early incident reporting by clinicians, open and ongoing communication with patients and family, our focus for much of today, but also good event analysis and quality improvement, financial resolution that's proactive in situations where patients were harmed by errors or system failures, care for the caregiver, we'll talk about in just a moment, and as Carole has said, patient and family involvement throughout the response to harm events is critical. There are multiple benefits of these programs. Not only do they preserve trust and meet patient and family expectations, they lower clinician distress, they lower litigation, they drive learning and culture, lower the likelihood of disciplinary actions, and increase the trust of the public in the ability of the healthcare profession to respond appropriately when something has gone wrong in healthcare. But the problem that we see across the field is one of inconsistent implementation. And we estimate close to 500 healthcare organizations have adopted some degree of a communication and resolution program, which is great, but they're using them inconsistently, either for some cases and not for others, or the use of some, but not all of the communication and resolution program elements for an individual case. And the reason why this inconsistent implementation is such a problem is that it fuels the concern of skeptics that these really are all about communication and resolution programs are actually a claims management strategy. They raise doubt about our commitment to openness, but ultimately, the reason that inconsistent implementation is such a problem is that fewer patients, families, and clinicians, as well as organizations, benefit from the communication and resolution program process. So we and many others in the field are working hard to try to understand how can we drive the implementation of highly reliable communication and resolution programs as a way of building, maintaining, and restoring trust. Well, it's important to drill down on exactly what are our goals in the immediate aftermath of a harm event. And Carole started us off with a great list, but I'd like to continue with that line of thinking. The desired state shortly after a harm event includes patients being alerted to what happened, having their immediate medical and social needs addressed, given regular updates on the material facts about the event, how clinical consequences are being addressed, and plans to prevent recurrences. If we had more time, we could spend an hour talking about what do we mean by material facts? How do you decide what information to share and what information not to share after a harm event? They're informed about what our approach is to supporting you going forward. They're given emotional support, including an apology. They're encouraged to ask questions and receive a timely response. They're provided with consistent messages from all the clinicians caring for them, not in a conspiracy sort of sense, but we want the clinicians to be working together and being able to communicate with one voice. Mixed messages, I think, is really upsetting and unfortunate and makes life much more difficult for patients and families after harm events. And then lastly, and in some ways, the most challenging is we want patients and families to be supported in ways that meet their individual needs. Carole already told you at the outset how important it was when sharing information to understand what is it that this patient and their family want to know and meet those needs. How do we know what patients and families want? There's only one way. We can't predict. There's no algorithm. We have some general guidelines, but ultimately you need to ask. Ask over and over again with patients and families, how can I support you? What are your needs? That's the only way to really customize and make the communication and resolution program process meet the different needs of individual patients and their families. And clinicians have needs. And we'll talk about peer support in just a moment, but communication and resolution programs are not only about building trust with patients and families, but also about maintaining trust amongst the clinicians who were involved. Back then to the issue of communication. Communication and resolution programs have many elements in addition to communication, but the placement of the word communication as the first word in the name of communication and resolution programs is intentional, because communication is the bedrock of the CRP process. But unfortunately, sometimes the reflexes that we talked about can lead clinicians to make offhanded comments to patients and families immediately after a harm event that can set the stage for everything that follows. For example, there was a case where a nurse's aide was escorting a patient to the bathroom. The patient fell, and out of the nurse's aide's mouth came, "I've told them the lighting by the bathroom door is too dim." Why did the nurse's aide say that? The nurse's aide had reported his or her concern to the organization before, felt like it was not listened to. They felt like that was the reason why the patient fell. Unfortunately, the patient and their family, when they heard that, they assumed that environmental causes were behind the fall, when it turned out that that wasn't the case at all. Or a nurse who says, "I've paged the doctor again, hopefully we'll hear back soon." If something doesn't go well, what do you think the patient and family will assume about the reason for that? Or the clinician, the surgeon who comes in for a consultation and says, "I wish they had called me sooner." The challenge here is that if there are offhanded comments like this, they severely impair trust. And when trust is impaired from the outset, regaining that trust, if the initial harm discussions with the patient and families go poorly, is extremely difficult. So there's a very high premium to be placed on ensuring our frontline clinicians are equipped so that they can interact with patients and families effectively in the immediate aftermath of a harm event. Some of this we call Harm Communication 101. We talk about patients' needs for truthful and accurate information, emotional support, including an apology, and follow-up, sometimes involving compensation. But healthcare workers have needs as well. Getting those early conversations well often benefits from coaching. They need emotional support. And it's important to understand that this is a process. It's not a one-time event. In fact, Carole and many of the other patient advocates that we work with have made a very eloquent case that the word resolution in communication and resolution program is really the wrong title, the wrong word, because it implies that somehow this is done. And for patients and families, that's never, ever the case. So seeing this as a process that has several steps and continues until the patient and family says it stops is important. It's beyond the scope of our time today, but there is a lot of outstanding training material and resources to help get these initial conversations with patients and families right, trying to point out the things we should do and the things that we shouldn't do. And we can talk more about these a little bit later if you would like. But some of the things that are really difficult to avoid, I will just spotlight speculation. It's so tempting for clinicians to speculate about what might have happened. That does a real disservice to patients and families, or to ignore the emotional cues that patients and families are giving us, and sometimes in a well-meaning way, trying to encourage the patient to focus on the positive, to move forward, to problem solve emotion when it arises. All of these things communicate that we really don't care about what happened or don't understand what the patient and family are going through. But I'd like to give you a specific example. What do we know about the impact of open communication on patient and family trust? Well, this was a case that was many years ago at the University of Washington Medical Center, where almost 600 patients were exposed to endoscopes that were not completely disinfected. All of the steps in the disinfection process had been completed except for the last one, which was shortened more than it should have been. But the risk of infection, the infectious disease experts thought, was essentially zero. But nonetheless, the University of Washington decided it would inform all 600 patients who had had endoscopies during that period of time of this problem with the cleaning, and encourage them to come and get tested for any bloodborne pathogens. And then our research team, a few years later, reached out to these patients to ask them what they thought about this communication process and its impact on the way they viewed the organization. We got surveys back from about half of the eligible respondents. Almost 100% agreed that the university was right to notify them of the problem. Almost 2/3 were somewhat or very concerned that this endoscope cleaning breakdown might have caused health problems for them. But when it comes to two of the domains of trust that we talked about, the results were interesting and encouraging. 94% said that the notification had either increased or unchanged their perception of UW's honesty and integrity. And even more interesting to me, 78% said their perception of the quality of care provided by the University of Washington, the trust in their competence, was either increased or unchanged. So at least some early evidence that we can be open about problems in care, and if anything, increase rather than diminish trust. We don't have time to talk at length about one other important element of communication and resolution program, which are care for the caregiver or peer support programs. When I've been involved in serious medical errors personally, I've largely just put my head down and thought, you know what happens, and moved on to the next patient. Not particularly effective for me. You certainly wouldn't want to be the next patient that I rounded on. The field is making good progress at programs to build trust with clinicians after harm events. And I hope all of you at your organizations have care for the caregivers or similar programs in place to support clinicians after harm events. For those of you who are interested in more information, the collaborative that Carole and I are involved in is partnering with Ariadne Labs and the Institute for Healthcare Improvement on a new learning community that's called PACT. And Carole leads our Patient and Family Advisory Committee, and the name PACT came from them, the Pathway to Accountability, Compassion, and Transparency. This is a breakthrough series collaborative that launches next month for organizations that have already been starting their work on communication and resolution programs and would like to accelerate their implementation and reliability. And we're almost full, but would love any other interested organizations in reaching out and letting us know. So when we harm patients through the process of healthcare, trust is at a premium, and the way we respond to those harm events is really the ultimate stress test of, are we committed to patient-centered care? Are we committed to building, maintaining, restoring trust? Communication and resolution programs are one important way that we can achieve that goal. Let me pass things back to Carole for a few closing thoughts.
So, Tom, I just want to make a comment on two things you said. The first is organizations have done a great job on building programs to care for their providers. However, these programs don't exist for patients and families. We are the ones that are also physically harmed, emotionally, so many other things, and yet there aren't programs out there to care for us. And when we say that, it may mean for years. The more that organizations don't tell us the truth, we aren't able to deal with our own grief. And when we can't deal with our grief and what has transpired, we cannot take care of our children and other family members. So the first thing is that honesty, it's that transparency. But the second is to start thinking in your organizations, how do you care for us? When we may lose our jobs, we have mental health issues, we have financial issues, we have emotional issues, we have children that have issues. And we need to take that next step to make it equivalent to care for patients and families like you do providers. I think what I just said is summed up beautifully on this slide. Are you willing to go there with us, to be honest, transparent, and sit with us when we're at our absolute worst? Next slide. It takes years to build, seconds to break, and forever to repair. In my own personal story, where I shared earlier that it took the organization 3 years, 7 months, and 28 days to have the first honest conversation with me, that was step one in trying to repair trust. It took more years for me to build up that trust. In fact, I have another child, and he required surgery. And I had to go back to the very same organization where my daughter died, and they weren't truthful with me and honest with me to get his care. That built another step in our trust. And over time, I actually now sit on their board for quality, safety, and the oversight committee. And the medical director and I have gone out and talked about what happened and how we got to this faraway space and how we were able to come back together. And the key thing that was the common denominator was we wanted to make sure what happened to me and my family didn't happen to anyone else, and there was learning from it. So finding that element that is mutual for both entities, harm patients and families in the organization, that's where you can start to have those conversations again to build trust. So Tom, if we want to open it up to questions. So I know there were a couple of comments in the chat, and I know we want to address different things. There was one comment that it went in there, and it's about vernacular that patients and families don't care for. So I want to frame up front, we believe in the concept, it's the terminology, and that is the term second victim. We wholeheartedly believe that providers, nurses, clinicians, physicians, allied health need to be cared for. It's just the term second victim. One, when you speak to a lot of providers, they don't like the term victim because when you're a victim, it's like you're rendered powerless. But it's now become there's the first victim, the second victim, the third victim. And patients and families are like, well, we're the true victim. And yet all these other people are claiming victims. So I'm just putting that out there. That's why you're seeing the terms more of like care for the care provider or different words used like that.
There were two questions that occurred somewhat earlier. And I do want to just encourage people to put questions in the chat or raise your hand if you'd like to ask a question. But one thing that several people raised during the video and that you touched on a little bit, Dr. Gallagher, in one of your slides was this idea of liability. So many of the people who suggested that she was less forthcoming in the video were suggesting it was because of liability reasons, but your slide clearly said that it helps with liability. Could you talk a little bit more about that?
When I started this work almost 2 decades ago, I remember the prevailing belief at that point in time was that it was liability concerns that were getting in the way of doctors and nurses being more open with patients when things had gone wrong. And I was planning a research study about this, and Lucian Leap said to me, Tom, this is not about fear of liability, this is about shame and embarrassment. Our data, of course, proved Lucian to be right yet again. It's not that doctors don't worry about liability. It's just that those fears are not linked in any clear way to the actual liability environment itself. And it's clear that in the aggregate, being open with patients about harm events, if anything, decreases the chances of being sued. Now, there will be individual circumstances where being open with patients is what brings the harm event to their attention, or it makes it clear to them that the harm event was due to an error or system failure. And those are patients who deserve compensation. But the literature is clear now that effective communication and resolution programs do not increase the chances of liability, and in many circumstances, they've been shown to decrease it. But we've been getting, as a profession, very conservative advice over the years from risk managers, from defense attorneys, and others. But I think at the end of the day, it's just hard for clinicians to sort of confront that shame and embarrassment, and difficult to have these awkward, uncomfortable conversations. And unfortunately, patients and families end up paying the price of our sort of our lack of skill at engaging with patients and families. But that's what we know about the link between liability and conversations with patients and families about harm. Carole, would you add anything to that?
Yeah, we don't really want to sue. I mean, that is just more harm to us, just like it is to providers having to go through it. When you read the literature, they did a survey after patients went to litigation, and the number one reason that patients sued is they didn't know what happened in their care. No one would tell them. No one was honest and forthright. And again, it goes back to, we carry all this guilt and grief and this need to know what happened to us or to our loved ones.
There's an interesting question which might be outside the scope of what you've studied, but one participant asked about gendered expectations of providers in complex communications, such as error disclosure. Any thoughts on how gender plays a role?
I can just talk about what we know from the research, and Carole would love to hear your observations. When we've surveyed thousands of physicians across specialties, across ages, gender has not been a predictor of their attitudes about communication following harm. Specialty is a powerful predictor. Interestingly, the liability environment is not a predictor at all. We compared US and Canadian physicians. The liability environments are very different. Their attitudes about this are almost indistinguishable. So I think some people have looked at the lack of any evidence about gender impacting this process and said, well, the culture of medicine, the culture of healthcare is so strong that it swamps some of the differences that you might expect to see around gender in this area. But Carole, do you have any observations about whether you think gender of clinicians plays an important role in this process?
No, Tom, I think the most important thing is, we all know in organizations those people that are good communicators and those who aren't. And you need to be careful if one of the providers is not a good communicator, to perhaps someone else be there to help them communicate, or I don't want to say buffer, but while patients and families want the various providers there that, harm them, some of them just don't know how to be empathetic. They don't know how to use the words that are important to patients and families. So having someone else there who is a good communicator to help them is really, really important.
And Carole, this will be just a little bit stereotypical, but I do think that it's true. When we watch physicians have these conversations, the element of the conversation that they struggle with the most is the emotion handling. This is something that our nursing colleagues, especially our more experienced nursing colleagues, tend to really excel at. is the emotion handling. And that's why we recommend that dyads have these conversations. It's helpful to have someone else in the room regardless, but if you pair a clinician with an experienced bedside nurse or ER or ICU OR nurse, it really seems to help these conversations. And there may be literature about nurses' skills in empathic communication, but anecdotally, we've observed that they really excel in an area that physicians more often struggle with.
So we have a time for a few more questions. So I do want to just take a moment and see if there's anybody who would like to unmute and ask our presenters today a question. Just pause for a moment to. Okay, so nobody wants to talk, but we do have another thing in the chat. So someone suggested that teams led by cognitive scientists would perhaps be effective in this situation. Is there any research, or do you have any experience with cognitive scientists being involved?
Well, I think the comment in the chat is calling out two really helpful things. One is MITS, which is a program that our colleague Linda Kenny founded that now has been incorporated into the Betsy Lehman Center at Massachusetts. Linda is a patient advocate who experienced medical errors herself, and then really did an amazing job of creating an organization to support patients and families and clinicians after harm events, which was named MITS. So that's a great reference. And for those of you who are interested in safety science, a lot of organizations are involving cognitive scientists in the event analysis process. MedStar, for example, is an organization that has an especially strong group of cognitive and system scientists who can really help organizations analyze these events in new and important ways. So I think both aspects of that comment are right on.
Yeah, the human factors getting involved, like you're saying, Tom, from everything from how we interact, humans interact, with one another, with machines, all of that, but the cognitive steps as well. MedStar really does bring them in the cause analysis and looks at a lot of those steps along the way.
I think this will probably be our last question, but one person, and this person I believe is still online, so they're welcome to jump in if they'd like. But one person said that some situations escalate between patients and allied health. What's the role of the physician in that situation?
But I would just fundamentally say we deliver healthcare as teams. And so all of the team needs to be equipped to work in an interprofessional and respectful way with one another when there's been a problem. We've seen situations where in that the team, the nurses or APPs or medical assistants are really, in essence, supporting the physicians and vice versa. We really should be just working as interprofessional teams when something has gone wrong to quickly huddle, talk about what happened, and think about how we can support one another after a harm event.
The other thing I want to add to that is it's often assumed that we want to talk to the person that has harmed us, and that's not always correct. And so what I try to teach organizations is, as Tom said, this is a process. There's certain conversations that happen right after. But as you go through, especially if you have lost someone, no one usually asks who we want in the room when we have these final conversations. And I was very specific of who I wanted. And I did not get 2 of the 3 people that I wanted. Still to this day, I don't know what has happened. But it wasn't who the organization thought I would want. So again, when you're having the bigger conversation, when you're going over what has happened, when you're, talking about the event, it's really important to ask the patient and family, who do you want in the room? Because sometimes they don't want the person that harmed them. They can't see them, they can't face them. And, it's really important when you're going to have these conversations that the right people are there to move the process forward, to try to keep that trust or rebuild that trust.
Well, I want to thank both of you so much for joining us today. And Carole, in particular, thank you for sharing your story, which made all of this so much more relevant and real. But both of you provided such great information, and there was great dialogue. So I appreciate your time today and all the time that you took to prepare for this. And I want to thank everybody for attending today as well for this very important topic. We hope that you'll also register for January's webinar, which is with Philip Alberti, who's the founding director of the AAMC's Center for Health Justice, and Pamela Browner-White, our Chief Diversity, Equity, and Inclusion Officer, and Senior Vice President of Communications here at the ABIM and the ABIM Foundation. You can see the registration link for that in the chat. And again, thank you everyone for attending, for staying this whole time, and just another thank you to our speakers who gave just a wonderful talk. Thanks so much.
Thank you.
Bye-bye.